Okay, folks, I think we're going to go ahead and get started so we can get you guys out of here. So how many of you guys are ready to wrap this up with the last presentation of the day? Okay. You're supposed to hold your cards up, not raise your hand. Okay. Doesn't matter which color you put up there. All right, I appreciate you guys hanging in there. Those were two great presentations. A couple things just to build upon now that you guys have seen a couple of the presentations from our two presenters that's going to be helpful from an exam standpoint is, as you have seen, the 4 answer choices may include answers that are reasonable options. And the whole exam is geared towards you picking the best of those options on there. So there's not going to be one glaringly right option in most instances. There may be ones that require you to review the case, and there may be a nuance to the case that makes one answer best to the other. The other thing is, it's for pediatrics and geriatrics, amongst the other things we're going to talk about, is the exam is largely based on guidelines. So we talked about in preparation, I would go to the preparatory course and review the recent guidelines, which most of us put in there, to make sure you have the most recent up-to-date information, okay? And again, just to reiterate, guidelines that have come out since April 1 are not going to be viable options for questions for the exam. So you should have everything at this point that you need to prepare for the exam in the fall. Does that sound reasonable? Okay, great. All right, so we're going to talk about gastrointestinal disorders as the last part of today. And I realize that as you guys flip through the book, it constitutes a large section of the one book, so it's a long chapter. And my justification is it's the longest organ in the body, so it needs the longest chapter. Okay? Not really. It's because BPS dictates that I have to include all the disease states that are in there. Okay, we're not going to have enough time to get through all the disease states that are in the chapter. So what I've done is kind of pick out some of the highlights, and I'm going to try to get through most of the cases in the book today. I want to at least get through the information on viral hepatitis with you today, because that tends to be a hot topic nowadays, particularly with the new drugs and guidelines coming out. So if we can get through that, I'll be happy, and then I'll be happy to address any other questions that you guys have. So if you look through the chapter, I have nothing to disclose. These are all the disease states that are in there, and we're going to focus on some select few today. Some of them are going to be more common and apply to both ambulatory and inpatient. Some of them are going to be more specific to inpatient, but hopefully this information will be helpful for you guys in preparing. All right. So let's talk a little bit about patient case number 1, which is on page 14 of your handout. I don't want to spend a whole lot of time on gastroesophageal reflux disease because most of you have been encountering patients with this disorder for a long period of time. And the most recent set of guidelines is from 2008, and from a treatment standpoint, nothing much has changed. So when we were talking about gastroesophageal reflux disease, it's still going to be standard treatment. There are new guidelines that are being put together and should be out soon that will address some of the controversies we're going to talk about. But from a treatment standpoint, we still have pretty much a similar approach to what we've been doing for patients for years and years and years. So let's talk a little bit more about some of the more hot topics, particularly with the PPI class of drugs. And so this patient case, if we look at it, is a patient who's a 55-year-old man with GERD who is getting started on the drug esomeprazole. Okay. Now, if you look at the top 200 list of drugs in the United States, where is the esomeprazole listed? Probably number 1.5, right? Along with the other 5 PPIs, which round out the top 10, right? So you all are seeing patients on these drugs. You can see some of the other conditions the patient has, and also some medications that they're on. So let's talk a little bit about now that they've committed this patient to long-term PPI therapy, what are some reasonable baseline testing parameters to get before the patient starts their therapy? And here's some options for you. We'll come back to these. So just think about these in relation to the case. In regards to the treatment, like I said, there's not been anything earth-shattering over the last couple years in the treatment of reflux disease. We still use either one of 2 approaches. Start patients on what we call the step-up therapy, which is antacids, stepping up to then H2 blockers and then PPIs, or more commonly nowadays, particularly for patients with frequent GERD symptoms, what is referred to as the step-down therapy, starting with a PPI and then stepping down to an H2 blocker and then eventually an antacid. Okay. How many of you guys in practice have been successful once patients start on a PPI of stepping them back down to an H2 blocker? Okay. You will have to pry the PPI from the patient's hands, right, before they will let you go. Okay. So with that being said, there's still going to be the go-to drugs for most instances. Metoclopramide is going to have a role in patients with delayed gastric emptying as a add-on promotility agent. Okay. Surgery is always an option for those of you guys who are working in large medical centers where you see patients who are refractory to acid suppression and metoclopramide, and it works great, but for most intents and purposes, it's going to be medical management. Now, the recent information in regards to safety issues with the PPI class of drugs has led to several labeling changes over the last couple years for the PPIs that I think are worth reviewing because these might be viable things that you guys get asked about. So the big ones, as you know, in relation to PPIs in general, if you look at the package insert for PPIs, and we're talking the prescription versions, 3 things have been put in there: risk of fractures, hypomagnesemia, and risk of Clostridium difficile infection, which is the most recent warning in there. What I think is most appropriate for you guys to take home from this is if you notice that the first bullet I have under clinical management of these disorders is the best prevention is not to be on the drug. Okay, so as pharmacists, one of the things we always need to do is if the patient is at risk for one of these adverse effects, can we take them off the PPI? So at least ask, is it a reasonable option, or does the patient really need a long-term acid suppression? If they do, then most of the conditions we're talking about here, the risk is relatively low, particularly for fractures and risk of Clostridium difficile infection. However, anything that the FDA gets worried about enough to put in the package insert is at least something we need to think about when patients go on these drugs long term. So for any of these side effects, particularly hypomagnesemia and fractures, trying to limit dose and duration is a reasonable option. Particularly with hypomagnesemia, the longer you're on it, the more at risk you're going to be for that adverse effect. From a fracture standpoint, again, the odds ratios, when you look at the studies, most of which are retrospective, are pretty low, in the 1 to 2 range. As of today, there's really not any recommendations from the gastroenterology organizations or the endocrine organizations that starting a PPI is an indication to do a baseline bone mineral density test. Okay? If the patient qualifies for that test for other reasons, as in they're at risk for osteoporosis or osteopenia, then it's a reasonable option. But the general population doesn't need a baseline screening test for bone mineral density just because they're using a PPI. However, we want to do everything that we can do to minimize risk of fracture, and those would be things like appropriate calcium and vitamin D intake. But remember, nowadays, not too much calcium, right? So someone else is going to talk about that. And then certainly other risk factor prevention like fall risks and appropriate calcium vitamin D intake, getting outside and getting in the sun if you can. As far as hypomagnesemia goes, this is thought to be potentially related to absorption issues for dietary magnesium. You can see limiting dose and duration. Most of the studies that went back and looked on this, patients were on it long term, or they were on other drugs like diuretics that promoted loss of magnesium as well, which becomes additive with the PPIs. The package inserts always say if you're on other drugs, like digoxin, for instance, if the patient becomes hypomagnesemia, that may increase the toxicity of other drugs like digoxin. That might be a reasonable indication for at least a baseline test and then periodic monitoring of magnesium concentrations further down the line. How many of you guys have been successful at supplementing hypomagnesemic patients with oral supplementation at high doses? Okay, it's one of the best laxatives that we have, right? So we're talking about the GI disorder, so that's appropriate. So certainly patients can go on oral replacement with things like magnesium oxide, but just realize that a lot of times if they become extremely magnesium deficient, that the oral products just aren't going to cut it, okay? So we're going to try to limit things that cause people to be hypomagnesemic. The C. diff issue is there for sure, and you're certainly going to run into patients who develop diarrhea while they're on PPIs. And certainly the package insert says that telling patients that they need to present or call their healthcare provider if they develop persistent diarrhea that may look like C. diff, to at least let someone know, and then decide whether or not the patient needs to be tested for C. diff. FDA says that it's reasonable to test for it if the patient has persistent diarrhea, and then they even go on further to say that if you run into a patient who develops C. diff who's on a PPI, that it would be considered a MedWatch reportable adverse effect. Okay. How many of you guys have reported C. diff diarrhea just because of PPI use recently on MedWatch? Yeah, you'd be pretty busy if you were doing it, right? Because most of the patients that we see, 99% of them are on a PPI, right? So MedWatch would be overflowing. So let's go back to this patient case then. So this patient is going to start long-term esomeprazole therapy. Before initiating the therapy, what would be a reasonable thing to do based on the patient case? So did they need bone mineral density? Did they need a magnesium, a potassium, or did they need a chest x-ray? So what do you guys think? Okay, so I'm seeing some reds. Okay, good. So I would agree with you guys. Serum magnesium in this case would be the appropriate option in this patient. The patient is at risk for developing severe hypomagnesemia because they're on other medications that may be problematic when that develops or may promote magnesium loss. So of all of those, certainly getting a baseline serum magnesium. It's easy to do if the patient's coming in for a routine visit, and it's easy to follow up on later on down the line. So as far as the PPIs go and reflux treatment, that's all I'm going to focus on because the safety issues are going to be the biggest thing that you guys are probably going to get questions on nowadays. The new sets of guidelines that are coming out, hopefully within the next year or two, are going to make some recommendations and further address these issues for you. All right, so let's move on to patient case number 2, which is on page 19. So in this case, we have a patient who's 68 years old, who presents with heme-positive stools and anemia and abdominal pain. Gives some recent history of NSAID use, in this case ketoprofen, and has a history of past medical history of diabetes, peripheral neuropathy, hypertension. Current medications you can see there: metformin, aspirin, gabapentin, and lisinopril. So this patient undergoes endoscopy, which would be a reasonable option if the patient was suspected of having peptic ulcer disease. And lo and behold, they show up with a gastric ulcer with an intact clot. And patient is H. pylori negative via the CLO test. So let's talk a little bit about which one of the following treatments is best for this patient at this point in time. So let's assume this patient, even though they got endoscopy, is going to be managed as an outpatient, because we'll talk a little bit more about gastrointestinal bleeding later. So which of these options would be reasonable? H2 blockers, combination of H2 blockers, or PPIs with other drugs, PPIs, or misoprostol? So from a peptic ulcer disease standpoint, again, there's not been a whole lot that's changed recently in the management of peptic ulcer disease, but you at least should be aware of kind of what the recent guidelines say as far as prevention and treatment goes. The big two that most likely you would get questions about would either be NSAID related or H. pylori related peptic ulcer disease, because those are the big two that we encounter in the United States. Certainly that most of these patients are going to be either suspected of having an ulcer based on recent NSAID use, or those of you guys who work in the ambulatory care setting may be seeing those patients who fall into the test and treat category for H. pylori, where they're suspected of having an ulcer, they don't look like they have reflux, and a test is done like the urea breath test or the fecal antigen test for H. pylori, and then patients are treated for H. pylori after that. So as far as NSAID-associated peptic ulcer disease goes, certainly you have to look at the drugs the patient is receiving. As you guys know, there are more COX-2 selective drugs. Currently, celecoxib is really the only one we have on an outpatient basis. There are some drugs that approach the selectivity of COX-2, like diclofenac and those types of drugs, which are often called COX-2 preferential agents. One thing to remember about risk of gastrointestinal bleeding and ulceration for patients receiving NSAIDs is that there are certain risk factors that put people at risk. Why this is important is if you get questions about which patients qualify to be on a preventative therapy, which in this case would either be a PPI or misoprostol, the risk factors that I have listed up here are definitely ones that the guidelines say are viable things to use to put patients on preventative therapy if they're going to be on chronic NSAIDs. Certainly advanced age, patients with a prior history of peptic ulcer disease, particularly those with complications, the big complication being GI bleeding, would definitely be a person who you'd want to have on a preventative therapy if you're going to have them on a long-term NSAID. If you combine NSAIDs, again, with other drugs that increase risk of ulceration, like corticosteroids, things like prednisone, anticoagulants, and this includes the newer anticoagulant drugs, in addition to heparins as well. Those would be indications for using a preventative therapy, and then low-dose aspirin as well. For patients that are being committed to long-term NSAID use, the guidelines do recommend that you test and treat for H. pylori ahead of time if you can. That has been shown to reduce the risk of developing ulcerations later on. And then if the patient does develop an ulcer later on, there's less of a chance you're going to wonder why, if it was the NSAID or the H. pylori. But they both are independent risk factors. As far as managing NSAID-associated peptic ulcer disease, so in this case we have a patient who has presented with an NSAID-induced ulcer. So in this case we always want to reevaluate the need. Does the person need to be on a long-term NSAID as their main go-to drug for pain management? Or, based on their condition, can we use adjunctive therapies or other therapies instead of NSAIDs? By far, as we talked about, if the patient shows up with an ulcer, H. pylori testing is recommended. And in this case, acid suppression with a PPI in particular would be the favorable thing if the person truly had an NSAID-induced ulcer that was not H. pylori positive. Okay. Some other things to remember in regards to the other drugs that are used to prevent NSAID-induced ulcers. Misoprostol is a great drug. It actually, from the data on preventing ulcers in NSAID users shows that it actually is probably better than PPIs. But as you guys know, there's serious issues with it in regards to tolerability. And it tends to be a great laxative as well, right? So we don't see misoprostol used all that much. But if the patient could tolerate it, it's certainly a good drug. You may see it used in some instances. I know our GI group uses it in patients who have developed ulcers, in patients who are already receiving a PPI as kind of a second-line therapy. Okay. Just remember that celecoxib, and I think Dr. Dugan talked a little bit about this in her presentation, even though celecoxib is the most selective agent we have, a lot of the patients who need preventative therapy for NSAID-induced ulcers don't meet the criteria for using celecoxib because of the cardiovascular risk. So my recommendation is even though we're talking about gastroenterology for this presentation, when you're considering celecoxib, you also have to look at the patient's comorbidities. And if they do have a high cardiovascular risk or they're on aspirin, that's probably not the best drug to go to from that standpoint. Okay, so let's go back to the patient case. In this case, which one of the options would be best for this patient? So an H2 blocker, combination of a PPI with antibiotics, a PPI, or misoprostol. What do you guys think? All right, so I'm seeing a lot of green. So that tells me you guys are still somewhat awake, which is good. All right, so I would agree with you guys. In this case, lansoprazole is going to be our go-to drug. So the patient has an H. pylori negative ulcer. It's been chalked up to having NSAID use as the cause, and therefore removal of the NSAID if possible, and then institution of a PPI should heal a gastric ulcer within about 8 to 12 weeks. If the patient then were to go on to require continued NSAID therapy, they would meet the qualification for being on a preventative therapy like a PPI or misoprostol after that. In this case, H2 blockers have not been shown to be as good as PPIs in preventing NSAID-induced ulcerations. However, as many of you guys may have seen, there is a new product on the market that has famotidine and ibuprofen in it. So in the famotidine dosing is high dose. So the product is called Duexis. I believe I put it in the chapter for you guys. So that does have an indication, but again, no comparisons directly to PPIs. So PPIs, in my mind, are still kind of the go-to drugs. Misoprostol, good drug for prevention, but once the patient develops an ulcer, not the best drug to heal the ulcer at that point in time. So you want to have something that promotes acid suppression. Okay. So let's go on to a different version of this case, or a different case on peptic ulcer disease, rather. So this would be a slightly different patient. A 42-year-old patient with epigastric pain, some relief with OTC and antacids, no real medications, but a penicillin allergy, and someone did a test for H. pylori, which in this case comes back positive. Okay. So let's talk a little bit about how the management of this patient would differ based from the first case. So we want to talk about which one of these options is best for treating H. pylori infection in this patient. So we have several different combinations of antibiotics here, along with several different combinations of acid suppressive drugs. Whoops. So in this case, let's talk a little bit more about diagnosis of H. pylori. How many of you guys are currently working in the ambulatory care setting? So a few. So most of you guys, everyone else pretty much hospital-based? Okay. So you may be seeing, those of you guys in the hospital-based, more of the invasive tests where patients are coming in, getting tested, particularly in the setting of a GI bleed. Those of you guys in the outpatient setting may be seeing the other tests used, like the urea breath test and the fecal antigen tests. One thing to remember is even though we're not diagnosticians, we need to know which tests are viable options for both diagnosing H. pylori, but more importantly from our standpoint is once patients get treated, what are the appropriate tests to follow up to see if the eradication has been successful. So the take-home message from this is, in the ambulatory care setting in particular, the non-invasive tests are preferred. All three of the non-invasive tests can be used from a diagnostic standpoint. And as you know, there's issues with the serology because it remains positive after the infection is eradicated. So the urea breath test and the fecal antigen tests are the most popular for both diagnosing and then confirming eradication following treatment. So just keep that in mind. If you're working in the hospital setting like I do, you see a lot of patients getting scoped. They get a biopsy. It's sent for histology to rule out malignancy. And they often do rapid urease testing. Now, rapid urease testing can be affected by PPIs, as can urea breath testing and fecal antigen testing. So sometimes the serologic test is sent as a backup in case there's a false negative with one of those urea-based tests. Okay, so if both are positive, that's strong evidence that the patient truly has H. pylori infection. All right, so treatment of H. pylori. Nothing too much has changed recently in this, although you guys may be seeing some different regimens used. The recent guidelines from 2007, and there's been recent guidelines from the European Coalition, the Maastricht guidelines released earlier this year, really still advocate triple therapy and quadruple therapy as the two mainline options for H. pylori infection. So using drugs in these categories would be the preferred way to go. So from the standpoint of both of these regimens, the guidelines do say that they're both reasonable options as first-line therapies. If you look at them stacked up once against each other, the quadruple therapy tends to be slightly more effective than the triple therapy if you can get the patient to take it. And the things to remember is the longer you can treat, as in 14 days, those are the highest rates of eradication. Now, there's several different issues with both of these regimens. The triple therapy regimen, the big issue nowadays is clarithromycin resistance. The regimens are only about 80 to 85% effective because of cross-resistance to H. pylori with macrolide antibiotics, particularly because of rampant use of drugs like azithromycin, right, which has cross-reactivity with clarithromycin. Unfortunately, you can't test for clarithromycin resistance ahead of time, so when you opt to use triple therapy, you got to make sure you retest just to make sure that you don't run into a H. pylori resistant organism. Unfortunately, it's a genetic mutation, and if you have it, and it's not gonna work, and therefore you have to retest for it. Quadruple therapy also has issues, as you guys know, bigger pill burden, right? But more effective, okay? And if you can get the patient to go to 14 days, that's the highest rate of cure of any regimen that we currently have totally. Now there's some advantages to this regimen. Certainly if the patient has a penicillin allergy, you could use it. The other regimen, though, you can substitute metronidazole in for or amoxicillin if you choose to do so as well. So you have a couple options there. Metronidazole resistance is an issue with the quadruple therapy, but the doses are high enough that it overcomes it in most instances. The big one that mostly you guys are probably dealing with is shortage of tetracycline, right? So you guys are probably getting calls about what do I do in this instance. So we want to try to reserve some of our other regimens like fluoroquinolone-based regimens because fluoroquinolones are being overused. Doxycycline's also on shortage, right, which is problematic too. So unfortunately, the studies that looked at doxycycline, minocycline, they don't work as well as tetracycline, but you can certainly use them. If my preference would be minocycline just because of the shortage of the other two. However, if you're going to substitute antibiotics out of there, the guidelines still recommend doing that, but that's certainly an indication to make sure you retest to see if you've had success. Okay, so let's go back to patient case 3. So this patient had a H. pylori-induced ulcer. They had a penicillin allergy. So what would be the most reasonable option for this patient? So we have a couple of triple therapy options. We have a quadruple, and then we have a levofloxacin-based option. So what do you guys think? So I'm seeing a lot of green. Okay, good. So I would keep in mind those two options. In this case, I would agree with you guys that the quadruple therapy, which is coming out of the screen at you guys, is going to be the most appropriate one. So I would keep that in mind in regards to as an alternative for patients with penicillin allergy. One other thing to remember is it's also an alternative for patients who have failed the triple therapy. Fluoroquinolone-based regimens are viable options, but the guidelines do say that that's probably a third-line option. You should reserve it for patients who don't qualify for the other two or fail the other two. Okay. There's also that regimen out there that some of you guys may be seeing, which is sequential therapy, which is use of a couple antibiotics for 5 days and then a couple more for 5 days after that. Any of you guys seen that recently prescribed for patients? It's not really caught on. The guidelines don't endorse it at this point. So I would say for purposes of the exam, that's probably too gray of an area, and I would focus just on quadruple and triple therapy. Okay. So let's shift gears a little bit. We're going to move a little bit into inflammatory bowel disease and talk a little bit about patient case 4. So this would be a patient that you might see who shows up with ulcerative colitis, one of the two forms of inflammatory bowel disease, and a patient who looks for all intents and purposes like their disease is not well controlled because they're having to be on corticosteroids for long periods of time, and when the dose is reduced, the patient has recurrent symptoms. Okay? Patient is currently receiving a drug that looks like it's a reasonable option for this type of condition, which is an aminosalicylate, and then has been on prednisone 40 milligrams for 1 year. So let's discuss some of the options. Should we change to sulfasalazine? Should we go to an immunosuppressant like methotrexate? Should we add infliximab on? Or should we go to mesalamine suppository? So keep those in mind. Whoops. I don't know why the answer was highlighted already. I'm jumping the gun. All right. Pretend you didn't see that. It's like a Jedi mind trick, right? You didn't see that. All right. In this case, for inflammatory bowel disease, the questions related to this, first and foremost, as we talk about, you need to know the differences between the two conditions. There are slight differences between ulcerative colitis and Crohn's disease, which are the two subforms. In this case, ulcerative colitis, by definition, is confined to the colon. The main thing to remember about Crohn's disease is it can occur anywhere in the GI tract. But the terminal ileum is the most common place that you encounter it. Crohn's disease tends to be more aggressive in that the penetration below the intestinal barrier is more aggressive, and so you get things like abscesses and fistulas more often in patients with Crohn's disease. And so it tends to be more aggressive of the two. Both conditions can result in patients having to have recurrent surgeries. Neither condition is curable, with the exception of ulcerative colitis, which can be curable by performing a total colectomy. Okay. However, if you're like me, you like your colon and you want to keep it around as long as you can. So we try to manage patients medically as long as we can. The other reason you may see patients with ulcerative colitis get a colectomy is if they have a high rate of colon cancer or colon adenocarcinoma in their family, which is ulcerative colitis is a risk factor for. As far as drug treatment options, we could spend all day talking about the various options, and what I want you guys to get out of this is, of the options that we have available to us, where do they kind of fit in? So there are guidelines for both ulcerative colitis and Crohn's disease. They're separate sets, and I've included those for you in the chapter, so I would suggest you guys go back and review and try to put some of them in table form to make it a little bit easier. But in general, where to start with this patient population is first and foremost, which disease do they have? Some drugs are only indicated for one of the two versions of inflammatory bowel disease from an FDA-approved standpoint. You need to know the severity. So is it active or is it in remission? Some drugs work great to induce remission and also maintain remission. Some drugs are only indicated to induce remission and not as maintenance therapies. You need to determine the extent and location. So one of the things I would look for in the patient cases is, where does the disease extend to? So does it extend all the way up through the colon? Is it located in the small intestine? Is it located just in the rectal area? And this is really going to dictate the drug formulation, particularly for the aminosalicylates and the steroids that you pick. Then you pick drugs based on the onset, so you need to suppress them quickly. Formulation, which is patient preference a lot of times, effectiveness and potential for adverse effects. Now, one thing I'll say about formulation of the drugs for inflammatory bowel disease, and I put this in the chapter for you, is that the formulations of the drugs are designed to deliver some of the drugs directly to the site of action. So oral drugs, by definition, will treat the points at which they release down on, further on down into the gastrointestinal tract. Topical refers to things like enemas and suppositories. And the general rule of thumb is that a suppository is only going to treat about the first 20 centimeters or so of the rectal area, whereas enemas can treat up to about the splenic flexure, which is the descending colon. So keep that in mind when you compare topical versus oral agents. The topical drugs tend to work better for the aminosalicylates in particular because you're delivering higher concentrations to the area. But you can certainly combine the two. You can use oral and a topical preparation both at the same time. Okay, here's in a nutshell for both conditions kind of what I would remember. Both categories of disease, aminosalicylates like mesalamine are appropriate options. They tend, however, to work better for ulcerative colitis than they do for Crohn's disease. But because they're fairly well tolerated, they're viable options for both. Budesonide is another option, which, as you guys know, is a high first-pass corticosteroid, which has indications for both conditions. There are two separate formulations of budesonide that I would keep in mind. One is an ileal release, which is the product Enrocort, or Enrocort EC, rather. And then there's a new one that just came out within the last couple of months, which is called Uceris, which is a colonic release that's indicated for ulcerative colitis. So if the patient is failing an immunosalicylate or you want to utilize budesonide in place of immunosalicylate, that's totally viable. The guidelines for Crohn's disease in particular say that budesonide is actually more effective than the immunosalicylates. However, the thing to keep in mind is that budesonide formulation only releases in the terminal ileum ascending colon. So if the disease is located outside of that area, it's really not an option. So if the patient falls into the category of mild to moderate severity, those two drug classes would be viable first-line options. If you step up then to more aggressive disease of the moderate to severe category, you can then think about adding things on like biologic agents and or immunosuppressants. So the TNF-alpha inhibitors have become quite popular in both conditions. You can see here that there's two that's indicated for ulcerative colitis, which is infliximab and adalimumab. And then all three of them, which certolizumab is the third, are indicated for inflammatory bowel disease. Okay. Azathioprine or 6-mercaptopurine or methotrexate are alternatives to the biologic agents. The thing I would remember about those drugs, though, is their onset of action is much, much slower than the biologics, particularly for azathioprine, and therefore, if you need sooner relief and you have more aggressive disease, a biologic may be preferred. The one other patient population where biologic agents are preferred are patients with fistulizing Crohn's disease. By far, those classes of drugs, the TNF-alpha antagonists, have been shown to be most effective for fistulizing disease. Corticosteroids, what you need to remember there, these are systemic corticosteroids like prednisone or methylprednisolone. They're really meant to be used short-term to suppress acute inflammation, and then patients should really be put on other drugs like aminosalicylates or biologic or immunosuppressants as their kind of maintenance therapy. Because of the prolonged adverse effect profile of corticosteroids, they're really not considered maintenance drugs. Even budesonide, which has indications for up to about 8 to 12 weeks. So that's pretty much the max we want to use corticosteroids in. This drug, natalizumab, is really a last-line therapy. So that is a integrin inhibitor that's really used kind of as a last-ditch effort for patients that have failed all other drugs. And that's really only indicated in Crohn's disease. All right, some of the key safety concerns that you guys should be aware of. TNF-alpha antagonists, there are several contraindications to using them, and you want to keep those in mind, particularly things like infections. And you want to screen patients for infections prior to starting therapy. One of the newest warnings on these drugs is the development of T-cell lymphoma, and this is most problematic in patients who are using it in combination with azathioprine. And the highest risk patient population in that case is young male patients. So even though that combination of drugs works well, and there's a couple large studies that have come out in the last couple years to show that you get really good results, that is a real risk, and it now is in the prescribing information. And if you have a younger male patient in particular, you really want to weigh the risk versus benefit of using that combination. Anti-motility agents we want to avoid, like loperamide or anticholinergics, until we get a drug on board that's addressing the inflammatory response. Azathioprine and 6-mercaptopurine, the thing I would remember about those drugs is that the FDA states that you should test the patient for the activity of the enzyme that's involved in the metabolism, which is thiopurine methyltransferase, or a TPMT. Before you put the patient on the drug to determine whether or not they need a lower dose. If the patient has low enzyme activity or has a phenotype that's absent of that enzyme, they may need much, much lower doses, or maybe not even the drug at all. As far as methotrexate goes, there are several things to worry about there. Bone marrow suppression, pulmonary and hepatic toxicity, renal toxicity is another one. However, at the doses that we use, it's relatively well tolerated. Corticosteroids, again, we want to try to use them short-term, so that most of the adverse effects are related to short-term use, but certainly like the patient we're talking about, long-term use can be problematic. Natalizumab, the black box warning there is PML. This is a drug, remember, that was used first and foremost for multiple sclerosis, and therefore that's the reason why it's really kind of considered a last-line agent. All right, so let's go back to this patient case. They have ulcerative colitis, and they would be considered, in this case, dependent on corticosteroids. They're on valsalazide, which is an aminosalicylate, which is a reasonable option to start. And based on the patient has pancolitis, which means the majority of their colon is affected, an oral aminosalicylate would be the first-line option. This would be pretty indicative of a patient who would be now considered corticosteroid dependent. They can't come off of corticosteroids, so our whole goal is induce remission, maintain remission, and get the patient off of corticosteroids. So in your guys' minds, what's the most appropriate drug option here? Should we change to another aminosalicylate, Add on methotrexate, add infliximab, or add a mesalamine suppository? What do you guys think? So I'm seeing a lot of green. Okay, good. I would agree with you guys. So in this case, infliximab would probably be the best option. So they would now be considered corticosteroid dependent. The biologics are great at corticosteroid sparing effects and therefore would allow the patient eventually, hopefully, to come off of prednisone. Methotrexate would be a viable option. However, this is kind of a nuance of the guidelines. Most of the data is with Crohn's disease. And so if you had a contraindication to a TNF-alpha antagonist, you could certainly consider methotrexate or azathioprine. Changing to another aminosalicylate at this point or adding a suppository is really not going to do much for the patient. The patient's already failed aminosalicylates by the fact that they have to be on high-dose corticosteroids long-term. Okay. This patient would be a patient with Crohn's disease who has more severe presentation. This is case 5. 2-day history of abdominal pain, fever, fatigue, and 10 to 12 bloody stools. If you work on an adult internal medicine service like I do, this might be the patient that you might see who comes in with an acute flare of IBD. If you work in the ICU, this patient could certainly be a patient who comes in with severe enough symptoms to land in the ICU as well. In this case, the patient's on an aminosalicylate, and so what would we want to do for this patient? So what do you guys think here? So would we want to go up on their Pentasa? Would we want to add cyclosporin? Call our good friends, the surgeons, to come in and whack out the colon? Or use high-dose IV corticosteroids? What do you guys think? All right, so I'm seeing a lot of yellow. Good. So in this case, I would agree with you guys that hydrocortisone is probably the go-to drug. So the take-home message here is if you see a patient who's hospitalized with inflammatory bowel disease, you need rapidly active anti-inflammatory drugs, and the guidelines dictate the first go-to drug class is IV corticosteroids at an equivalent dose of about 300 milligrams a day of hydrocortisone. We use methylprednisolone a lot at about 60 to 80 milligrams, and that works fine too. Surgery and cyclosporin are a last-ditch effort before the patient is failing medical therapy, and increasing the dose of the oral aminosalicylates is really not going to do much at this point in time. The person needs rapid suppression of the inflammation to get it under control, and the best drug class to do that is IV corticosteroids. Okay. All right, let's keep rolling on to patient case number 6. All right, so we're going to talk a little bit more about the liver now. And this patient has a 47-year-old patient with nausea, abdominal pain, and fever, cirrhosis. They come in with some abdominal tenderness. And we can see here that the patient's on a pretty routine regimen for cirrhosis, which is furosemide, spironolactone. The patient undergoes a diagnostic paracentesis, and you can see there some laboratory values that are indicative of the fact that maybe the patient has some issues related to cirrhosis. And so what would be the best plan of action? And we're going to focus really on one of the complications, or a couple of the complications in this case. So what the recommendation is best at this time? So this patient, by definition, as we'll talk about, would probably be considered a patient who has SBP or spontaneous bacterial peritonitis. And what would be the best option? So albumin plus antibiotics, or oral antibiotics. So we'll talk a little bit about what the options are. All right, many complications of cirrhosis, okay? This does not mean you guys can't go to happy hour after this presentation, though, right? Okay, this is a long-term complication of the condition, and I will see you in there myself after this, okay? So with that being said, we don't have enough time to discuss all the complications of cirrhosis, so I would recommend you guys go back and review the chapter. I've also had some self-assessment questions on the other complications in there, which I think hopefully you guys will find helpful. All right, SBP is one that we see commonly, though, in patients who are hospitalized. Some things to remember about SBP is it's considered a primary peritonitis. So in other words, there's not a secondary source. And really the diagnostic criteria is based on the white blood cell count and the acidic fluid. So as long as that's above 250 neutrophils, that buys you a diagnosis of SBP. Even if the patient has no other signs or symptoms of infection. The main pathogens we worry about in SBP are our typical enteric gram-negative organisms like E. coli, maybe some streptococci in there as well. The main thing to remember about SBP is it does put patients at risk for things like hepatorenal syndrome, which has very, very high mortality. And then once patients develop SBP, they've pretty much bought themselves a lifelong continuation therapy for secondary prevention, which is unfortunate. All right, so as far as treatment option goes, all the original studies for SBP were done with third-generation cephalosporins, and then the guidelines recommend adding albumin on there. Okay, the albumin recommendation really comes from the fact that because during episodes of SBP, patients may have loss of intravascular volume. There's a couple large studies that have been done to show that adding albumin on prevents development of hepatorenal syndrome in the setting of SBP. And so this is why many of you at your hospitals probably have a protocol for the SBP patient who comes in and gets albumin on day 1 and day 3, based on a couple of those big studies. There's also recommendations in the guideline that if the patient meets certain criteria, you can put them on albumin as well. And these are the most recent ones that I would look at for this patient in particular. So primary prevention can also be used during a GI bleed. So the guidelines say if the patient comes in with a varicose bleed, they're also at risk for SBP, and therefore antibiotics would be indicated. Acidic fluid protein, serum creatinine, you can see here, sodium or bilirubin can also factor into whether or not you need to use albumin as well for the patient. Once the patients develop SBP, again, any patient with a prior episode qualifies for secondary prevention, and really we want to put those patients on long-term oral antibiotics. So what I would remember for SBP and this patient population is if the patient is hospitalized, at the minimum they're going to need antibiotics, and whether or not they need albumin is going to be dictated by this criteria. And then once the patient develops SBP, once they go home from the hospital, they're going to need a secondary preventative regimen. That's either going to be a non-absorbable fluoroquinolone like norfloxacin, or a poorly absorbed one, or trimethoprim sulfamethoxazole, or a fluoroquinolone like ciprofloxacin, which is routinely used as well. So if we go back to this patient case, this is a hospitalized patient who has SBP. If you look here, they have a white blood cell count that's way above 1,000, and therefore they would qualify as a diagnosis for SBP. You can see here that based on the criteria, if we look at the need for things like albumin, that the patient does appear to qualify based on some of those criteria that are in the guideline. So which would be the recommendation that you guys would have for this patient at this point in time? So I'm seeing a lot of green in there. Okay, good. So I would agree with you guys, and therefore we're going to paint that one green. All right. So albumin by itself, is that going to treat the infection? Not really. So at the minimum, you need an antibiotic. Third-generation cephalosporins are the most popular. Cefotaxime is the drug that most of the original studies were done with. We tend to use ceftriaxone a lot as well, too. The albumin dosing would be appropriate as well, and you guys can look at the regimen for that as well as for the two-dose administration. Vanco and Tobra would not be appropriate. You're not addressing the organisms, or you would be, but it would put the patient also at risk for renal toxicity. And you probably don't need that broad of a spectrum because MRSA is not really all that well involved with SBP. And then oral trimethoprim sulfa would be an appropriate thing for the patient to go home on as a secondary prevention, but we want to avoid that as the primary preventative treatment for SBP in hospitalized patients. Okay. All right, keeping it within the realm of the liver, we're going to move on to patient case number 7. So this would be a patient who would come in with another complication of liver disease, which is upper gastrointestinal bleeding. The patient has a history of cirrhosis, alcohol abuse, and MI. And in this case, the patient undergoes endoscopy, and you can see there's several large esophageal varices, and the patient undergoes esophageal variceal band ligation, which is one of the more popular procedures now for acutely taking care of gastrointestinal bleeding. So when we talk about upper gastrointestinal bleeding, for purposes of the exam, there's 2 flavors that you have to remember. There's non-variceal, which is a separate set of guidelines, and then there's guidelines for managing peptic ulcer disease-related bleeding, which are also separate. So in this case, I want you guys to remember the drugs that we use to treat variceal bleeding in particular, because they differ a little bit than what we see in patients with peptic ulcer disease. So what do we do for this patient in the setting of an acute variceal bleed? Beta blockers, vasopressin, octreotide, or our good friend the PPI. Okay? So keep those in mind as we talk about this case. All right, variceal bleeding. So as far as varices go, most patients with a diagnosis of cirrhosis are going to be screened intermittently for presence of varices. So once patients get a diagnosis of cirrhosis, they're typically undergoing a screening endoscopy to see if they have large enough varices to go on primary prevention for bleeding. And you can see here that the bleeding risk is real. It's very, very high. And once patients have an episode of bleeding, there's very, very high recurrence of bleeding, particularly within the first month. So we want to do as much as we can to prevent the first bleed the patient has, and once the patient develops a variceal bleed, then secondarily prevent that second one from happening. So this is where the drug therapies and the endoscopic therapies come in. So as far as treatment of variceal bleeding goes, when patients first present to the hospital, a lot of times with upper gastrointestinal bleeding, you don't know until you scope them if it's an ulcer or if it's a variceal bleed. So some classes of drugs, like PPIs, are going to be indicated just because you don't know what you're dealing with yet, and you don't want to miss that as your first intervention. However, the guidelines state that for patients, most patients, endoscopic intervention is the way to go, to at least to start. And if you're fortunate enough to be at a site where you have an acute endoscopy suite where you can do this, that's great, because patients can get banding, they can get sclerotherapy, and those are great interventions as well. Now, the medical management of the variceal bleeding is really geared more towards preventing the rebleeding associated with those varices within the first 3 to 5 days. So the endoscopic interventions, particularly for large variceal bleeds, are really going to do most of the work. The medical interventions are really going to be geared towards stabilizing the patient and preventing rebleeding, which is the major complication that we worry about. So the go-to drugs here are either vasopressin in combination with nitro, or more commonly octreotide, which is going to reduce portal pressures and splanchnic pressures and prevent rebleeding. Remember that we talked about, much like for SBP, when patients come in with variceal bleeds, they are at risk for developing SBP, and therefore there is a recommendation in the guidelines to put the patient on a course of antibiotics in the setting of their acute variceal bleeding. So in our institution, we tend to use a lot of ceftriaxone for that, or your third-generation cephalosporin of choice is fine. So those are the kind of interventions that we want to remember. How many of you guys use vasopressin and nitro for acute variceal bleeds at your institution? Yeah, not a whole lot of love for that combo, right? Particularly because of the cardiovascular effects associated with vasopressin in particular. All right, so octreotide tends to be the most popular one. It's fairly well tolerated. And then octreotide in combination with your antibiotic of choice would be the recommendation at most institutions. As far as prevention goes, primary prevention really is a call based on whether or not the person has small varices that are considered high risk of bleeding, and this is really going to have to be determined by the gastroenterologist. Is there stigmata associated with those varices that look like they're going to blow sooner than later? If they have medium to large varices, it's a no-brainer. You try to put them on a preventative therapy. The go-to drug class in this case, non-selective beta blockers like propranolol and nadolol are the two that the guidelines recommend. Okay. Secondary prevention, you can kind of remember this much like SBP. Once you have a variceal bleed, you're on prevention for the rest of your life, either medically with beta blockers or intermittent band ligation if the patient has a contraindication to a beta blocker. Okay. So with that being said, I would remember non-selective beta blockers. They need to be non-selective, right? They can't be beta 1 selective because those don't reduce portal pressures enough to prevent rebleeding. So let's go back to our patient case. In this case, then, we have a 36-year-old patient with a variceal bleed that is post-endoscopy with band ligation. So what would be the best choice for this patient to prevent early rebleeding? So beta blockers, vasopressin, octreotide, or pantoprazole. All right, so lots of love for the octreotide. Okay, good. I would agree with you guys. So things to remember, vasopressin would be a viable option. However, it needs to be used in combination with nitro. And if the patient has a cardiovascular history, it's probably not a good option because of the risk of cardiac ischemia. PPIs would probably be on board for this patient at least initially until the endoscopy was performed, but again would not directly address the rebleeding associated with varices. Okay? The PPI infusion roles are really to prevent rebleeding in patients with peptic ulcer disease related bleeding. So the new sets of peptic ulcer disease guidelines say that regimen is indicated for peptic ulcer disease bleeding, not for variceal bleeding. Okay? However, as you guys know, the patient's going to stay on their PPI anyway, right? Just because it's good for them, right? And then they're going to get C. diff and hypomagnesemia, right? Okay. All right, patient case 8. So the last couple cases I want to spend some time on are hepatitis, because this is an area where I think a lot of questions are coming out recently, and I think most of the questions I get recently are related to both Hep B and Hep C. So here's a patient with hepatitis B, which fortunately in the United States is now become less common because of the routine vaccination and the good use of drugs that we have. However, in a lot of countries, particularly in Asian countries, hepatitis B is still a big problem. So let's talk about this patient case. They have a new diagnosis of Hep B. They certainly have certain things to support that with high LFTs. One key thing to remember about this case is looking for this guy right here, the YMDD mutation, which indicates resistance to certain drug classes or drugs within classes like the reverse transcriptase inhibitors. And this type of patient would certainly get a biopsy to make sure that there's no other cause other than viral hepatitis. So, should we not treat this patient? Should we treat him with PEG, interferon, and ribavirin, lamivudine, or tenofovir? So keep those options in mind. All right, hepatitis B, again, these are a highly guideline-driven disease state, so I'll hit the highlights for you guys on the guidelines. In the United States, you can see here that patients will qualify for treatment if they have chronic disease, 6 months or greater, elevated LFTs, and a high circulating DNA level of hepatitis B. Okay, one of the things to remember is that you have to also look at whether or not the patient has the YMDD mutation, and also whether or not the virus is able to express the E antigen, which is a marker of viral replication. If the patient has E antigen negative disease, they tend to be more difficult to treat, and the guidelines will address that separately from those patients with E antigen positive disease. We're not going to talk about difficult patient populations like co-infection with Hep C or HIV, but those are certainly more common than not nowadays, right, trying to treat co-infected patients. All right, here's it in a nutshell for hepatitis B. I would remember a couple drugs that the guidelines call out as reasonable first-line options. Regardless of whether you have E antigen positive or negative disease, you notice that entecavir and tenofovir are the recommended drugs in those two instances for both conditions. Interferon is an option if the patient meets criteria for it and is able to tolerate it. However, as you guys know, it's associated with a lot of adverse effects, and people are often more willing to take oral medications rather than injections that cause a lot of side effects. Either way, you're going to treat the person for a minimum of a year, okay? And so I would keep in mind the two drugs, E and T, entecavir and tenofovir, as the two viable options. You can see here that lamivudine and drugs like that have been around for a while. Because of the high rates of resistance, are really not recommended as first-line drugs anymore. However, you will have patients who have been on them for a while and are doing fine, and that's great. There are recommendations in there, and I would suggest you pull out the guidelines if you have a patient who's on lamivudine and then develops resistance and fails it, because they have recommendations on what you can do for those patient populations as well. So at the end of the day, from an initial start, entecavir and tenofovir are reasonable options. These drugs are relatively well tolerated, as you guys know. However, there are some things that have been added to their profile of adverse effects recently. Things like reductions in bone mineral density have been added in there. Some of them, like adefovir and telbivudine, have specific either muscular or renal toxicities associated with them. Those two drugs, again, are not really recommended as first-line options in the guidelines anyway, but just keep that in mind. So what would be the reasonable option for this patient? No treatment, PEG interferon and ribavirin, lamivudine, or tenofovir. What do you guys think? So I'm seeing a lot of love for tenofovir. Okay, choice D. And I would agree with you guys. So this person certainly would qualify for treatment because they have high circulating levels of DNA, they have high LFTs, and they have documented HBV infection. PEG interferon and ribavirin, that's more for hepatitis C treatment, right? And then lamivudine would be a viable option, but remember, this patient harbors the YMDD mutation, which makes it resistant to lamivudine, and therefore lamivudine is not a good option, okay? And I would go back and review other drugs like telbivudine if you have the YMDD mutation or cross-resistant with that mutation as well, and therefore not good options. Okay. All right, last one we're going to talk about, I think, just because this is a big topic and I want to make sure we cover it appropriately for you guys. So this would be a patient that is very, very common nowadays, and probably most of you guys are encountering at some point in your daily routine. So the patient with hepatitis C infection. In this case, we had a patient with genotype 1B infection. Using some ibuprofen, no allergies, and you can see here that there's lab evidence that the patient has elevated LFTs, a very high circulating level of HCV RNA, and then we can see their renal function and their bone marrow seem to be working pretty well at this point. So what would be the best options for this patient? Reassess, give them tenofovir, peg interferon and ribavirin, or go with the triple therapy, which is interferon, ribavirin, and telaprevir, which is a protease inhibitor. Okay, as far as hepatitis C goes, this is such a hot topic nowadays because, as you guys know, now there's recommendations to start screening people of the baby boomer generation, right, for hepatitis C. And so we're going to run into a lot more patients with chronic hepatitis C infection. In the United States, genotypes 1 through 3 are the most common. Genotype 1 is the most difficult to treat. Genotypes 2 and 3 are a lot easier to treat than genotype 1. As you can see here, it's the major cause of liver disease in the United States now. One of the most reason people get transplants nowadays is chronic hep C therapy. So chronic hepatitis C therapy has been updated recently, as you guys know. Within the last year and a half, there's been some new guidelines that are out, and I recommend you guys take a weekend to sit down and go through those. It will be very fun, I assure you. So the bottom line is that the guidelines have changed, and these guidelines apply to genotype 1 infection, which is the most difficult to treat. In the United States, the recommendation now is if you can use it, use triple therapy, which is peg interferon, ribavirin, and one of the two new protease inhibitors, which is telaprevir or boceprevir. Okay. So the genotype 2 and 3 infection, which are easier to treat, is still the standard peg interferon and ribavirin. So if you get a hep C case on the exam and it says genotypes 2 or 3, triple therapy is not indicated for those patients. Okay? We're really talking about genotype 1. Ribavirin and peg interferon you guys have experience with. In these patients, it's still going to be the same doses. However, there are some differences between the two protease inhibitors that are now available. If you look at the two drugs that are available, telaprevir and boceprevir, both work fairly similarly. However, there are some nuances to them in regards to dosing. Telaprevir is started at the get-go. Boceprevir is started a little bit later on in therapy. Both are indicated for genotype 1 infection. Okay, so both are reasonable options per the guideline. You can see here that boceprevir needs a run-in period. You need to be on peg interferon and ribavirin first for 4 weeks and then start boceprevir. Telaprevir, 12 weeks with peg interferon up front, and then continue the peg interferon ribavirin after the 12 weeks. So keep that in mind because there are nuances to when you start the two drugs. If you're given the option of telaprevir, it needs to be at the beginning of the therapy, not the 4 weeks into it like boceprevir. There are some unique dosing recommendations for this as far as frequency, some high-fat food recommendations as well for patients because some of the drugs are absorbed better in those instances. Both are contraindicated in pregnancy, mostly because of the ribavirin component of the regimen. Telaprevir has a black box warning for severe rash, so keep that in mind, that patients need to be told if they develop rash that they should call back to the clinic or the hospital and let someone know because this could progress into Stevens-Johnson's or TEN, and we don't want that to happen. Boceprevir, certainly higher incidences of anemia and neutropenia in combination with peg interferon and ribavirin. One of the things that you guys need to look for in the cases are contraindications based on drug-drug interactions. Both drugs are nuclear-level cytochrome P450 inhibitors, and therefore there's many drugs that are contraindicated. There's also many drugs that you have to look out for as far as dose adjustments go, particularly anticoagulants, statins, immunosuppressants. So just like you guys have done for years and years and years with protease inhibitors and HIV, you need to do the same thing with hep C. Look for the drug-drug interactions, get them off the drugs or switch them to something else that doesn't interact with them. As far as monitoring goes, we're really trying to shoot for this guy right here, sustained viral response, which is after you finish treatment, you have a negative HCV RNA at 6 months. That's considered the gold standard of treatment cure. As far as chronic hepatitis C treatment goes, genotypes 2 and 3 are easy. It's still the same recommendation of 24 weeks. However, genotype 1 with triple therapy depends. And this is where you guys are going to need to go back and look at the package inserts for either product because it's going to differ based on if you're using boceprevir or telaprevir. The bottom line is that each medication has instances where you look at HCV RNA and determine if the patient has had a good enough response to continue. If they have, then you can continue for the designated amount of time and then continue peg interferon and ribavirin up to about a year. If the patient has a really good response, you may be able to get away for about 28 weeks minimum. So the nice thing about these drugs is it's allowed shortening of the regimens if the patient is a good responder up front. So keep that in mind that it's not the standard recommendation to go to 48 weeks unless you have poor response up front. So here's treatment duration recommendations. Here's the other one, okay, for telaprevir. You can see here similar recommendations. You can go to 24 weeks total if the patient has a good response. Otherwise, you may be up to 48 weeks. All right. So with that being said, what are we going to do for this patient? What do you guys think would be the appropriate option? So we have genotype 1B, treatment-naive patient. What would be the best recommendation? All right, so we're going to go with triple therapy. And I would agree with you guys. So this patient would qualify because, they have genotype 1 infection. They have no contraindication medication-wise or history-wise to a protease inhibitor. Therefore, the initial regimen of peginterferon ribavirin would be appropriate for genotypes 2 and 3. This would be the best efficacy. Okay. The only other thing I would say is that this regimen would be appropriate. However, you would have to state, in my mind, the answer would have to say, at 4 weeks, I would add boceprevir in there if the patient had a good response. Otherwise, from the get-go, this would be the best one. So that's kind of the whirlwind treatment of hepatitis therapy in a nutshell. And so hopefully you guys, if you get a question on that on the exam, you guys will be good to go. All right, I'll hang around for a little while longer if you guys have questions about the other cases. Otherwise, I appreciate you guys hanging in there for day one. You guys have 1 day under your belt. And we'll be up here to answer questions afterwards if you guys have any questions on my stuff, Dr. Oler, or Dr. Dugan's material. Otherwise, you guys have a good evening. We'll see you guys during the rest of the course of the meeting.